Since we are discussing surgery today, and specifically oncology and surgery, we are going to be meeting Dr. Junaid Azad. Dr. Junaid Azad is a surgical oncologist who specializes in oncology, surgery and laparoscopic surgery as well. So let us come and meet him. Assalamu alaikum. There are two kinds of doctors. Either they're physicians or they're surgeons. The physicians are the unlucky ones because we have to keep giving medication and medicines and controlling the disease, and the patient is never really completely cured. The surgeons are very lucky because they find a disease, they diagnose it, and then it's gone forever. So we have with us today Dr. Junaid Azad, a general surgeon, laparoscopic surgeon, as well as specialist in oncology, right?
Yes.
So how are you, Dr. Junaid?
I'm good.
So you're the lucky one because, you know, as physicians, we get these complaints all the time from our patients that they keep saying, oh, I have to take this medication, I don't want to take it, I left it, side effects, we're not cured. Whereas the surgeon, the moment something is detected, they just do the surgery and then they become the great doctors of all times, right? So let's start with the most common surgeries first. So appendicectomy, for instance. People are very scared of appendicitis and they don't know the symptoms. So what are the symptoms? How do you go about it? How long does it take? Just a quick overview on appendix.
So appendicitis is inflammation of an appendix. Appendix is an organ inside the abdomen, inside your body. It's right on the junction of where the small bowel and the large bowel attaches. So the symptoms are that you feel pain on your right side, on the right lower end of the tummy. So it will be acute, sharp pain. So sometimes it starts in the belly button, around the umbilicus, and then after a couple of hours it shifts to your right lower abdomen. One is this. Second, you might have vomiting. And third, you might not feel to eat something. Right. So these are the three signs or symptoms of an appendicitis. So if you visit a doctor, especially a surgeon, he'll examine your abdomen and then he'll elicit some signs that he'll do, he'll press or palpate, what we call in medical terminology, your right side. Right. The moment he presses on this side, there'll be pain. So second, he'll ask you questions about how's your urine output, is there any burning, because the ureter is passing just behind these organs. So these are the signs of an appendix.
So it's an emergency, right?
Yeah,
Then why do but why do people, you know, avoid surgery? Why do people get scared of it and they keep trying to delay it and they keep thinking maybe it could be something else, it could be something else, and they're not able to identify that it's actually an appendix or an inflamed appendix and don't understand the urgency to get it removed?
So this is one of the plight of the general public. One, they're very scared. Right now, they're scared of being anesthetized. They're scared that what if we get a cut? So, but the science and research today, anesthesia is very safe in these days. So I do recommend that if you do have signs or symptoms of an appendicitis, you should visit the surgeon. And then let the clinician or the surgeon decide what's best for you. I do agree that early appendicitis could be managed conservatively. There is a trend in the world that early appendicitis can be managed conservatively, but there is a criteria. So that's why when you visit a surgeon, once he examines you, he will keep every examination, he'll give a score. And there it's called Eldorado scoring. So he'll score according to the Eldorado and then decide if you need an appendectomy or you can be managed conservatively.
Okay, does the surgeon only examine you and look for the, you know, rebound tenderness, or for example that point, McBurney's point, or whatever it is, but then, or do they run some other tests as well? What are those other tests that they run?
So diagnostic tests are done. I mean, you know, any disease or any symptom in a patient is incomplete without one, the clinical examination, second, the diagnostic test. So the diagnostic tests do attribute to the correct diagnosis in patient. So one is your CBC, which is a complete blood count. All right. So what the surgeon would see is the TLC, total leukocyte count. So leukocytes are cells that are involved in inflammation, infection. So one, he'll see that. Is it raised? Second, he'll see your CRP. Third, he can order an ultrasound. Now, ultrasound will tell if there is inflammation in the appendix. Once there's an inflammation, the body's reaction to that, there's edema. Edema releases fluid, so there will be periappendiceal fluid. So the gold standard is when the surgeon or the clinician is uncertain and the diagnosis is equivocal, then the gold standard is CT. The CT can 100%, it has a high sensitivity and high accuracy to differentiate, is it appendicitis or it's not an appendicitis.
So how fast do we need to act? Because in case we do not act that fast, there is a danger of the rupture of the appendix, and then it can be fatal as well, and then there's like toxemia and all of that. So how does that go about, and how do we prevent it? How fast do we take action?
So I think once appendicitis kicks in, so the patient should refer to a doctor or a surgeon to the hospital within a couple of hours. I mean, generally patients tend to wait, say that this is a pain, it might go off. But if the pain starts in the umbilicus and the shifts there, these are typical signs of an appendicitis. So, and if the patient has taken some over-the-counter medication like paracetamol or Tylenol or anything like that, and if it's not working, then I think that is the point when he or he should refer for medical care. Then, depending on what the examination reveals, the surgeon will decide how early it should be done.
Exactly.
But if you delay it more than 12 hours or 24 hours, the appendix will ultimately rupture. Once it ruptures, it can lead into peritonitis. Then the small cut won't do it. It is the big cut, which is called laparotomy, opening up the abdomen from center.
So a stitch in time does save 9.
Exactly.
So you have to have the stitch right in time.
Exactly.
They say, Dr. Junaid Azad, that the appendix is a vestigial organ, it's not required, but people get scared. What if their appendix is removed and something goes missing? So how important is the appendix? Why does it get obstructed? And in case one does undergo an appendicectomy, what is the life after that?
So yes, as you mentioned, it is a vestigial organ. Traditionally, appendix has some functions in immunity. Okay. It's a lymphoid organ. It has a function in immunity.
Just like tonsils?
Exactly.
Right.
And how does appendicitis happen? Once a feculate, what is something you eat and what passes through your intestines into the small and then to the large, a fragment of it gets stuck in the appendix.
Okay.
Then it obstructs it, it blocks it. So that's how the inflammation starts, and then the cascade goes on. So that's how appendicitis does happen. But once you remove it, your rest of the life, it is absolutely normal.
Okay.
So God has given some chances for the human being to live without some things.
Right.
And appendix happens to be one of them.
So it's okay to cut it and throw
exactly,
it away.
Sir. Absolutely.
Like a
okay.
toxic person around you,
Exactly.
it's always good to get rid of a toxic organ.
Exactly. Right? It's a toxic organ. You get rid of it, your abdomen will be absolutely
Yeah, the moment
fine.
it starts showing its anger or toxicity, you need to
get
get
it out.
rid of it.
Get it out.
Yeah.
And I should add here, the recurrent attacks. A lot of patients come in since they're afraid or frightened to get surgery.
Right.
They do insist that please give us antibiotics, please give us medicines. But let me tell you, if there are recurrent attacks, then that is much more dangerous than the first attack.
Exactly. And how long does an appendicectomy take ideally? How much is the time that they have to stay inside the hospital? And then how big is the incision? Is it a big ugly scar, or is it, are you able to hide it?
So traditionally it was just open appendectomy. Okay. Even in open appendectomy we do a scar for 2 to 3 inches, that's it.
Yeah.
That's
and then guys go around saying, I had a bullet here
exactly,
or a stab.
Exactly. So scars are good sometimes.
Right,
so not all scars come from wars.
Exactly.
Some come from the operating room. Exactly.
Yeah. Right.
So it takes about 40 minutes. I mean, the whole procedure in and out, getting anesthesia, doing the surgery, bringing the patient out of anesthesia. It generally takes 30 to 40 minutes. The patient might stay for a day maximum, and the next day we do discharge the patient. Okay. For 6 hours till the anesthesia effects are not completely weaned off, we do not advise for oral intake. But once he's alert and oriented, we do start oral and he can go home the next day.
And once he uses the washroom, then he's all free to use it.
So
this is one pain, one kind of abdominal pain. Now let's come to the other one, which is very common and unfortunately it's very rampant all around us. That's the pain of the cholecystitis, the gallbladder, the inflamed gallbladder. So how do you differentiate from this pain? How quickly do we need to act for a gallstone or a gallbladder inflammation, and what are the options available?
All right. For gallstone disease, which is also very common in Pakistan, it's more common in females than males, but now it's almost equal. One can be due to diet. I mean, our dietary habits in the last decade have changed dramatically.
Yeah.
So gallstone pains usually happens on the upper right side of the abdomen.
Okay.
Appendix on the happens
Lower
on
side.
the lower side of the abdomen.
Right.
This happens on the upper side of the abdomen.
Okay.
And this pain is a little spasmodic. It will come, go, come, go.
Okay.
So this also causes nausea and vomiting. But it is more severe, I would say, in nature. The
All right.
biliary colic is much more severe. The patient might want to press his abdomen, his or her abdomen, as something to relieve the pain.
Right. Okay.
So this is due to the inflammation of the gallbladder. So most commonly, inflammation of the gallbladder happens to stones inside the gallbladder. So gallbladder is an organ which is attached to the undersurface of the liver.
Right.
Its function is to store the bile. Bile is a chemical, or it's a liquid that helps in digestion of the food.
Exactly.
So the liver makes the bile and then stores it in the gallbladder. So when the stones are formed, what they do is
they block that passage.
They block the passage. So once the passage is blocked, there will be distension of the bile.
Right.
Second, the bile, in order to release what is stored inside, contracts. It presses on itself. Once there's stones inside, the moment it contracts, the stones touch the lining of the gallbladder.
And
They irritate the gallbladder, increasing the inflammation and then causing biliary colic.
So what do we need to do for it? To remove the stones or remove the gallbladder itself?
So ideally, like for example, this is a good question. I mean, a lot of people that come in, they ask the surgeon or they ask me, why don't you remove just the stones?
Yeah.
For example, especially if they or someone in their family have had renal stones or ureteric stones removed.
Exactly.
So they said, we never remove the kidney,
Yeah.
we don't remove the ureter,
Yeah, why are you removing
then
the
why are you
gallbladder?
removing an organ?
Right.
So for those stones, yes, you can do it. Because once they're attached to a passage, then the stone will pass into the ureter, to the bladder, and then outside of the body.
Right.
But the gallstone does not have a direct passage like that. One. Second, if the stone passes into the cystic duct, which is the duct connecting the gallbladder into the main duct, which is coming from the liver, the CBD, it can cause pancreatitis, which is a much more severe disease condition, just than the inflammation of the gallbladder. Then if it goes into the small intestine, it can block the passage where the small intestine and the large intestine meet.
Are connected.
Exactly.
Right.
So that will cause obstruction of the whole bowel, causing gallstone ileus.
Okay.
So number one, these are the reasons we don't remove the stones.
Okay.
Number two, even if removing the gallbladder will not affect your dietary habits, will not affect your life. So it is more safe and it's much safer for the patient as well to remove the gallbladder rather than opening it and then removing the
So
stones.
what are the precautions once a gallbladder is removed? How long does this surgery take? And after that, how soon can you come back to life? And what is the diet or the precautions that you need to take once you don't have a gallbladder?
So, as I mentioned, for even appendectomy and now the removing of the gallbladder is called cholecystectomy.
Yes.
These procedures before were performed open, meaning a scar was made.
Now it's only a little
Now it's a
incision?
keyhole surgery, which is called laparoscopic.
Okay.
Laparoscopic surgery has very small 5 millimeter scars, and we do it with those instruments. We remove the gallbladder, and now gallbladder surgery is a day case surgery in most of the European
So
countries.
you discharge the same day?
Exactly. The patient can be discharged in the same evening. For Pakistan, some centers might start it, but most of the centers do keep it for one day. The reason being patients travel from far-flung areas, that being one reason, and the patients are more concerned that if we go home, something happens.
So how do we get
exactly
control?
how we'll get in touch.
So since this laparoscopic surgery has, the advent of laparoscopic surgery, how has it changed everything? Because it bleeds less, the incision is smaller, the healing is faster, the infection is less. So do you advise people towards this kind of surgery more, and should it be in a tertiary care hospital with somebody who has the equipment and the training to actually do this kind of surgery?
Absolutely, absolutely. Laparoscopic surgery has changed, a paradigm shift, I would say.
Okay.
I mean, it's not one factor that it changes a lot of factors. One, that the scar is less. I mean,
Yeah.
you know, comparing a 10 centimeter scar of cholecystectomy
Just
with
a
5
hole.
mm
Hole,
scar
yeah.
hole is a big
Much
difference.
better, yeah.
So what happens to the patient? One, there will be decreased pain.
Right.
Now the pain, if the patient has less pain, the patient will be ambulating.
Right.
He would love to get out of bed.
Exactly.
But once the patient has pain, I mean, he would be so agitated that he does not want to move.
Right.
So once he's out of the bed, he's returning to normal function.
Right.
So one, decreased pain. Second, if the wound is less, or the scar is less, there are less chances of infection.
Exactly.
I mean, the bigger
It's
the
less
wound is,
invasive.
exactly.
Yeah.
So the less the wound, the less the infection. So less wound infections. Second, open surgery traditionally has had more adhesions,
Right.
which is post-operative
Exactly.
adhesions. Laparoscopic surgery does not cause adhesions. So
That's a very important point.
Very important,
Yeah.
because these adhesions can later on life, I mean,
Right.
5 years, 10 years, 20 years, can cause an obstruction of the bowel at any time.
Right.
So laparoscopic surgery decreases that. So there has been a lot of research.
What about the anesthesia used? Is it different in laparoscopic
No,
surgery?
the anesthesia remains the same. Because
And why do people have so much of fear of anesthesia? It's because of the anesthesia that they don't go into surgery rather than the surgery itself.
I think, yes, people do have a lot of fear that once we are anesthetized completely,
We won't come back.
we won't come back. So, you know, but nowadays anesthesia has become very safe. I mean, with the advent of new drugs, with new machines, new monitors, I think anesthesia has become very safe. And now, most of the centers, almost 99% of the centers, an anesthetist would also do a pre-op workup. I mean, he would evaluate the patient, grade him according to the ASA grading, and then tell the patients that if you're in, if there is any risk or not.
Right.
So, but yes, I mean, still changing that perception would take time.
So what are the investigations for before a cholecystectomy? We mentioned the ones for the appendicectomy, and what is it before the cholecystectomy?
An ultrasound. Ultrasound, there I said CT is gold
Right.
standard, but for cholecystectomy, CT will miss stones.
Oh,
So
okay.
an ultrasound, yes, CT will
Alright.
miss stones, but an ultrasound is a very good investigation. One, it is readily available. Second, it is cost efficient.
Okay.
Third, it gives you the exact size of the stones. It gives you size of the CVD, which is the main duct coming
Right.
out of the liver, and if there is stone or not, and the size of the wall of the gallbladder vessel.
And then we go for surgery for that.
Yes.
So now let's talk about another very common condition, especially in our part of the world, and that's piles and hemorrhoids. And unfortunately, it is very, very misunderstood and mistreated by quacks all over. And
Oh,
there are
yes.
people, you know, giving all sorts of formulations for it and ruining it even further.
Exactly.
What are the symptoms of hemorrhoids? Number one, what are piles? What are hemorrhoids? How do you differentiate it from anal fissures and fistulas? And what are the treatment options?
So you're right. I mean, these three issues,
Yeah.
I think they are so prevalent in the society that if you ask someone about piles or hemorrhoids, they'll definitely tell you, yes, I have one. I know someone who has one.
Exactly.
So, and the treatments that are, I mean, I've seen graffiti on the walls of
Exactly,
the cities.
everywhere.
You know,
Yeah.
they're prescribing different types of medicines,
Herbs
powders,
and-
herbs, you know. So, and they're giving guarantees
Oils.
that this will vanish, you know.
Right.
So, hemorrhoids or piles are the same thing. So these happens that they're anal cushions, you know. I mean, the place where we do pass feces
Yeah.
or we pass stool, they're cushions in the anus. So when they are dilated, the veins are dilated, they cause hemorrhoids. So there are degrees of hemorrhoids. First degree hemorrhoids are usually not that painful, they don't bleed much. Second degree will be bigger than those. Third degree is they do come out while defecating. So when
Then
you
they go
strain,
down,
they
yeah.
go in automatically. And fourth degree is that you have to push them back in.
Okay.
Or they might get stuck,
Right.
which is thrombose. So these are different degrees. So usually for the first degree treatment, we can do conservative.
Okay.
One is adding fiber to the diet,
Right.
decreasing
Refined
spicy,
flour. Yeah.
exactly, spicy foods, decreasing fried items.
Okay.
So anything that makes stool hard.
Okay.
Increasing water intake.
Right.
Water intake will also make the stool soft.
Soft.
All right. So for second degrees, we can do banding. This is a daycare procedure, is an outpatient procedure. It does not require even a local anesthetic. So there's bands, there's a gun, you go, you put a band on the neck of the hemorrhoid. 2 days later, the hemorrhoid falls off, the blood supply to the hemorrhoid is cut, it is necrosed, and then it falls off. For third and fourth degree, usually a surgical treatment is. So you don't need a complete anesthesia, but you do need a regional anesthesia. Spinal one. So the anesthetist will take a syringe, put medicines in your backbone, and then the lower half of your body will be anesthetized. You won't feel something. So now there's an open episiotomy. What is that? You take the hemorrhoids, you cut them, and then you stitch the base of the hemorrhoid. Second, and some centers in the West, there's stapled hemorrhoid. So there's a stapler, a stapling gun is inserted, the hemorrhoids are attached with the stapler inside, the staple is fired, and then the stapler is brought out.
What is a halo surgery? Is that similar to this one?
No, it's different.
Oh,
that's hemorrhoidal artery ligation.
Oh, okay.
So surgery. So that's a different. That's a newer approach, a new technique. But they're ligating the hemorrhoid. It's the same thing. You're obstructing the blood flow to the hemorrhoid. The end result will be the tissue will be necrosed and it will fall off. So that's one thing. So hemorrhoids are not always painful. First and second degree won't be painful. Third and fourth, especially thrombosed hemorrhoids will be painful. Anal fissure is painful. So anal fissure is that there is a breach in the lining of the mucosa, is a breach in the skin of that area. So the anal area, there's a breach, and this happens once either you have a prolonged diarrhea, especially because diarrheal contents are not irritating. They're not healthy for the skin even. So they're irritating, the skin is irritated, and then this Number two, if you strain a lot. So while passing feces, while passing stool, you have constipation and you're straining. So due to the pressure, there becomes a tear in the skin, and that is anal fissure. So anal fissure is painful. There might be bleeding in both hemorrhoids and anal fissure. So getting a checkup is mandatory before diagnosing either one. Fistula usually happens, there's an opening between the passage area and a normal skin. So that is a fistula. This is an abnormal opening between the skin of that area and then in the colon or in the rectum of that area. So this happens usually, it's a sequela of an abscess. If you had an abscess, which is inflammation, and there was a pus in that inflammation or a cavity.
Created a cavity.
Exactly. After that, once the inflammation is settled, or even if you've operated for that, there is a chance that the abnormal passage will happen. For that, usually a surgery is required, either a fistulectomy, removing the entire tract, or a fistulotomy, opening the tract so it fibroses and heals.
And for the fissure as well, there's a surgery to repair it?
Usually for fissures in the initial stage, we do never open.
So you just put a cyclone in there?
Conservative treatment. One is we take phytodiet, then we give ointments like lignocaine and glycerol trinitrate. They relax the skin so there's less painful, or else due to the pain, the patient, what it does, it controls or does not pass stool. They avoid passing stool. So that creates more problems, because the more the stool stays in, it becomes hard. So once that is there, they won't be passing stool. So we give conservative treatment. The second is we advise sitz bath, which is sitting in the tub. Relaxing that area so they can pass easily. But if there is a chronic fissure and it is refractory to treatment of conservative, then we go for a lateral internal sphincterotomy. We'll cut the sphincter, so the sphincter is relaxed and the pain is released.
What about a rectal prolapse? How do you differentiate that from a hemorrhoid that isn't going inside?
So the hemorrhoid is a small tissue or a small thing coming out of the area, or the rectum or the anus. Rectal prolapse is a complete tissue coming out. So it is a circle tissue. It is part of the intestine or part of the rectum that comes in, and the patient even can differentiate that there's an entire tissue thing is outside and it goes back in. So hemorrhoids are usually small things or small piles of tissues that come out and they go back in. Rectal prolapse will not bleed.
So rectal prolapse, and that also requires surgery.
That also requires surgery.
So why people are living with it? There's so many people in our society living with these things, and then they get complicated, thrombosed, strangulated, and all of this, right?
I think generally public in our society do not tend to give much importance or attention to their health.
Right.
I mean, my experience or what I've noticed is there might be 10 other things that they're giving more importance to, but when it comes to their own health, they'll have a lazy attitude. They'll just procrastinate. Then will go to a doctor. They'll keep delaying it. Number one. Number two is they're scared.
Right.
You know, I mean, what will happen? I might have something more sinister.
A post-op complications
exactly,
mostly, right?
more complication.
Yeah.
Number three is it's a taboo still. I mean, they're ashamed telling someone, or even talking to a doctor I've seen, that we have piles or something, you know, I mean, giving a detailed history. So I usually counsel them that there's nothing to be ashamed of. I mean, this is part of the body. It can happen to anyone. It happens to millions of people around the world. It's not this.
As you mentioned, the reason behind it is our diet.
Exactly.
This refined diet, less fiber, less water, more spices, more fatty food. So that's why we have all these conditions, right? Does posture have a role to play with it? Like a poor posture or poor bowel habits, for example, not going to the washroom on time. Do these things affect it or they don't?
Posture, I might say not much. Okay. I mean, but yes, bowel habits, yes, you're right. It has a lot of effect. I mean, as you mentioned, the dietary habits, even if you see in the last 10 or 15 years, our dietary habits have dramatically changed. I mean, we're taking more Western diet or we're going towards more fast food.
Exactly, processed diet.
Processed diet. Second, we're going more to a sedentary lifestyle.
Right, we don't move, we don't exercise.
Want to exercise.
Yeah.
We want to eat burgers, we want to eat fast foods, but we're not exercising. And there are a lot of unhealthy diets. So that plays an important role in hemorrhoids, especially spicy foods, barbecue. So this does have a crucial role. Posture itself does not.
What about pilonidal sinus?
Pilonidal posture has it. Posture
right.
has it, yes.
Yeah.
Pilonidal sinus, especially it was called Jeepers disease.
Right.
Because people driving Jeeps for long routes or bus drivers or truck drivers, they would have it because they would sit in that same posture for hours and hours.
Right.
So now, since the advent of technology, a lot of jobs require one to sit on the table, on the computer. So it's no longer just to Jeepers or truck drivers. So it's to also office jobs or people who are sitting. Exactly. So that does have a link with the posture. Second, it has a link of your undergarments if you're not changing them regularly.
Right.
Keeping the area dry. Once it is moist, it has more chances of infection.
And shaved, you need
to shaving that area improves your chances of not having it.
And if somebody does have a pilonidal sinus, for example, a bleeding lesion at their lower back, what do we need to do?
First, we usually give a trial of antibiotics. Once this infection has settled, then we go for surgery. Because if you go directly for surgery at that time, there's a chance the wound will infect.
It'll come again.
Yes, the wound will be infected.
Right.
So traditionally, for infected cases, we used to keep open wounds. But now open wounds are not much in favor, so we do close the wound. Why? Because the patients can go back to work, they can go into a normal lifestyle, and early back to work, they can be discharged. Having an open wound at the back of your body, I mean, you know, it's very difficult to have a dressing done. You can't see it. The access is difficult. So you need someone, even at home, who can do a dressing. So that it's very difficult for the patients as well. So we do prefer closing it. So for closing, there should not be any infection.
When we talk about closing the wounds or post-op care for any operation for that instance, you said cleaning and dressing and keeping it dry and the antibiotic cover, all that is very important. What about this other thing that you said, that some things are sutured, some are stapled, there are different ways of closing a wound. So what are the most latest ways of closing a wound with minimal scarring?
So closing the wound means that whatever wound you have made or the scar you have made, you primarily close it back.
Right.
So why? Because the body can heal, the wound can heal if you stay it open, but the scar will be it's a bigger scar, and it'll be an ugly scar.
Right.
But if you close the wound primarily, it's a small scar and it'll be just a line. So before there were only sutures. Sutures are threads that are used surgically to close the wound. Now there's staplers.
Right.
So staples are used to close the wound, so they have less imprint.
Okay.
The threads had more.
And
imprint.
you have to remove these staples as well later?
Yes.
You have to get them removed?
Yes, they need to be removed. So they will be removed in the OPD or on a follow-up.
All right.
So once you remove them, they're painless.
Yeah.
They leave a less imprint on the skin. Number one. Number two, if you have a wound on your neck or on the face, so these areas in surgery we call them clean areas.
Right.
And the blood supply in these areas is much better than the supply in your lower areas.
Okay.
Because your heart is near,
Yeah, it's
the
pumping,
pressure is more. So the blood supply here is good. So here we use threads or sutures that are absorbable.
Okay.
So they would not leave a single mark. So there will be a single line. They don't need to be taken out. With time, they'll absorb into the skin, and that's it.
Well, that's good. That's a very good advent
Yes.
in this
Exactly.
science and
So
technology.
that's more
now.
cosmetic.
That is
That's
more cosmetic, and we don't have to fear those ugly
Exactly.
scars
Exactly.
anymore. What about hernias, for example, if there's an incisional hernia or or there's hernia inguinally or anywhere a pouch sticking out? How do you fix that, and when do you need to get it fixed, and what are the precautions after that as well? Like for example, the mesh or the belt or whatever.
So hernia is any organ or viscus, usually small bowel or the fat inside your belly and the abdomen coming out through the skin.
Right.
So there's a defect.
Yeah.
So there's a defect in
The
the
mid-wall.
boundary wall
Yeah.
that is protecting all these organs. Incisional hernia, as you mentioned, is one that happens after a surgery has been performed in the incision.
Right.
Because once an incision is made, even if it's healed properly, it does not reach the 100% strength that
Exactly.
it was before the incision. So incisional hernia is that after surgery. Inguinal hernias are hernias that protrude through the inguinal canal. So these hernias always need surgery. I mean, there's no medicine that can treat hernia.
And how do you find out you have a hernia? If you're coughing, it's coming out. If you're
So,
straining, it's coming
exactly.
out. Either
So-
it stays out or it
Yes.
goes back in.
So hernias will be more evident once you do anything that causes
Lifting.
intra-abdominal pressure to rise.
Okay.
That is straining while on the sitting on the doing stool,
Toilet, yeah.
running,
Right.
exercise, weightlifting, or picking up grocery bags as well.
Coughing, sneezing.
Coughing, sneezing. So these all increase your abdominal
Intra-
pressure.
yeah.
So then the hernia will be more evident. I mean, it will protrude out. Second, an ultrasound is done.
Okay.
So the ultrasound will tell us, yes, this is a defect in the wall. It measures in three. It will give the size, and it will also give the contents of the sac. Either is it a small bowel, is it the omentum or the fat in the belly button, or anything else.
Right. Dr. Saab, you're wearing pink today, and we speak a lot about breast cancer, especially in October, but it's not October, but we're heading there.
Yeah, we are heading towards that.
we are heading towards that, and this is a huge taboo in our society.
Oh, yes.
Even if a woman does, notice a lump or some kind of change in her breast, she does not go for surgery, and she doesn't realize that if this surgery was done initially, it could save her life. And the more they delay it, the more invasive it's going to get, and it's going to become untreatable eventually. So let's talk about all the signs and symptoms of breast cancer, and what are the investigations, and if they go for surgery, then how much does it improve their chances of survival? Yeah.
Yes, you've mentioned it's a very important topic, and unfortunately, due to pressures of society, due to numerous reasons, it's still a taboo topic. Females do not like to talk about it. They're scared. They're frightened to talk about it. Even they're scared to talk about it within their own households, families. So, but the good thing about this is that breast cancer, though it is very common, even in our society, we have a very high incidence of breast cancers, and unfortunately, at a younger age, we are seeing it at a very younger age. But the good thing is, if it's diagnosed early, if it's treated early, the survival is extremely good. I mean, women can go on to live an absolutely normal life.
And that is why we keep spreading all this awareness that
Exactly.
once they detect it, they need to get it treated right away.
Exactly.
And can you explain it to them that it does not involve removing the entire breast or the arm or the axilla unless it's spread to that extent, and a little lumpectomy is also sufficient?
Exactly. So the first thing is, how do you diagnose
Right.
it? I think it's important that every female should know that whenever she feels a lump that was not there previously, she should get it evaluated. Get it evaluated from a female surgeon, get it evaluated from any surgeon, but get it evaluated.
Right.
So any lump that appears in the breast that was not present before should be evaluated. That is the bottom line. So for breast cancers, the societies or cancer societies, breast societies have developed an algorithm to diagnose it. One, it is called triple assessment, that you take a physical examination, that when did the lump appear, has it grown, any other changes in the skin, size, shape.
Right.
Second, you examine the lump.
Right.
Is it attached to the skin? If it's not, is it mobile? It's not. So this is one example. The second is you do a radiological investigation, which is mammography, which is an ultrasound, X-ray of the breast. Second, you do an ultrasound of the breast.
Right.
Third is you take a biopsy. It's a needle. You do
FNAC or
a core biopsy. The tissue biopsy is a gold standard. So this is the algorithm to diagnose breast cancer or for any lump of the breast.
Okay.
Number one. Now, with the advent of, there's a lot of research in breast cancers. Every single day there's a lot of research. As you mentioned that before, 20, 25 years ago, yes, the breast cancer was treated with complete removal of the breast. But now, BCS, which is breast conserving surgery, it is most of the time you can do it. I mean, for example, initially BCS started for smaller lesions. Slowly after research, even bigger lesions can have BCS with neoadjuvant chemo. Neoadjuvant means you first give the chemo, downsize the size of the tumor,
and then
and then preserve the rest of the breast and remove that.
Right.
So for early cancers now, even there are centers that don't give chemo. So they just take out those tumors, they take out that lesion, and then they keep the patient on follow-up. But there are specific centers, there's specific criteria that the patient has to have a very aggressive follow-up with his or her surgeon.
And the prognosis is very good with breast surgery, right? So
yes,
they don't have to feel scared.
Is very good. So if you delay it, now what happens if you delay it? One, if it's an early breast cancer, so we label as T1, T2 as an early breast cancers. The thing is, you can conserve your breast, you can conserve the breast, and then you just have to do wide local excision or lumpectomy.
Right.
But once it gets aggressive, what happens? That it involves the chest wall, it involves the lungs, it involves the lymph nodes in the axilla, it involves the liver, so it involves the spine. So there is metastasis, diffuse metastasis. Then it does not become treatable. Second, if it does not even get distant metastasis, the tumor itself becomes so big that it is absolutely not able to conserve the breast.
Right.
Sometimes it's not even possible to close those skins. So then you have to do flap, like an LV flap. You need to harvest the tissue from any other part of the body and then put it here and then close it.
So basically our message is that if you notice any change in the breast or the nipple, if it's inverted or if there's any lump anywhere that has changed shape, size, become leathery, or your skin looks like dimpled in or like an orange peel, or there's any sort of disparity between each and the other breast, then you need to go and get it examined.
Please do visit your surgeon. I mean, if females do have this issue, there are now very good female breast surgeons available in all the cities of Pakistan. So do visit. I mean,
and we have a lot of reconstructive surgery and plastic surgery available for reconstruction as well, right? Especially
for younger females. Now we do recommend that there's a reconstruction done or mammoplasty is done, so there's conservation of the breast.
Exactly. Moving on to malignant conditions, colorectal carcinoma is also very rampant nowadays in our society. We tend to ignore it because we keep thinking, oh, maybe I have IBS, I have constipation, I have diarrhea, and they keep ignoring all those symptoms. What are the symptoms of colorectal carcinoma? Why is it so common in our part of the world now? And it's not even confined to the old age. It's now there in younger individuals, and how do we go about that?
Yes, you're right. I mean, colorectal cancer is extremely common. It's getting very common in our society. I've seen so many patients, and you're right. I mean, traditionally it was a disease of the 5th or 6th decade.
Right, exactly.
I remember reading in our books
about 55,
during our medical college or undergrad that this is a disease that happens later in life. But now we're seeing patients 18 years old, 20 years old getting colorectal cancers. Number one, it is genetic. Number one, it is sporadic. There is a genetic role. Our tumor biology is very aggressive. Our tumor biology is very different from what we're seeing in some centers in the West. I mean, I've seen signet ring cell colorectal carcinoma or rectal adenocarcinoma very common in young individuals. And unfortunately, this is the most aggressive form of tumor, and it spreads very rapidly. Now, what are the causes? One is genetic. Second, is there a dietary cause? That is very less likely to say. I mean, there's no much difference of diet in different parts of the country. So, but some centers or different areas of the country report a higher incidence compared to other centers. So, diet, I would not say has a lot of. Yes, fiber diet is protective.
Okay.
Fiber diet is very protective against colon cancers. So, but our diet is fiber. I mean, we're eating.
We have a lot of carbs in our diet,
and we're
whole
taking
wheat,
whole wheat as
fruits,
exactly.
vegetables.
So fiber diet is protective, but is there any specific form of food that causes it?
Right.
No, I mean no.
Okay.
So the third cause is
yeah.
it's familial.
Yeah.
I mean, there's syndromes,
Families.
late syndromes. There will be familial. Then there are chances that you are more prone to get a cancer. Symptoms is constipation is number one, and this is a symptom that is ignored by most of the people.
Yeah.
People go to doctors, they don't do
stool
a proper
softeners, like
exactly.
Xanax.
They don't do proper examinations, proper investigations. They just write stool softeners, and then the patient is well. The patient forgets about it, and 6 months down the line, he comes to the emergency department with a perforated tumor or a completely obstructed one. So, second, it is PR bleed, which we call it per rectal bleed. Any blood coming from your anus is not normal at any time.
And in stool as well, if you see a dark colored stool.
A dark colored stool, which is melena, black stools, this means the blood is absorbed into the stool and changes the color or the consistency of stool. Fourth is that any change in bowel habits.
Right. So you have like alternating between diarrhea and constipation.
Constipation, or what we say is spurious diarrhea. In the morning, you go to the washroom, the initial stool is a little soft, and then it's all diarrhea. So that is spurious diarrhea. So that is also.
What about tenesmus, the feeling of incomplete defecation?
Exactly. Tenesmus is incomplete evacuation of the rectum. So
Okay.
that is also a critical sign of a tumor.
And do you have like rectal pain and bloating?
Rectal pain is there sometimes, bloating not necessarily. Rectal pain will happen while defecating or passing stool. So there will be a rectal pain, but not all the time. Most of the cancers are painless.
Oh,
Most of
so
the
that
cancers,
makes it even more dangerous because they're silent killers.
So they're silent killers. Cancer has always been labeled as a silent killer. The reason is cancer itself does not cause pain. It causes symptoms, but not pain itself. So defecating stool is one symptom, but that you won't see much with.
So having anemia or malabsorption and deficiencies in different vitamins and they presenting as symptoms are also a concern.
Because tumor, what it does is it creates angiogenesis. It creates its own blood supply. So that causes anemia. So most of the right-sided tumors of the colon will cause anemia. Left-sided will cause obstruction.
So this won't be evident on a blood test or on an ultrasound. It has to go through a sigmoidoscopy, colonoscopy, endoscopy. So when do we decide that one has to go for a colonoscopy, and how safe is a colonoscopy? Because people are very scared of going for that as well.
So there are red flags, we say. Red flag one is having bleeding per rectum. That is not normal. Second, if the age is above 50. But now I'm saying that age is slowly is becoming irrelevant. The reason is because we have seen this disease in a very younger population. Third, altered bowel habits. Fourth, doing an examination. If it's an upper colon or transverse or right, if the surgeon feels that there's a mass, it's not absolutely normal, then you need a colonoscopy. If it's a lower rectal, the surgeon might do what is a digital rectal examination. He'll take his finger and palpate all the mucosa of the rectum.
And when we talk about surgery, then resection is an option, and how good is the prognosis? And
so it depends, where the tumor is located. For anywhere in the right colon, in the transverse colon, or in the sigmoid colon, which is left colon, if once the investigations are complete, which includes your blood investigations, there are tumor markers. For example, for colon cancers, there's CEA. All right. Then there's a colonoscopy. They'll take a biopsy. That biopsy will tell if it's malignant or if it's a tumor or not. Then the CT is done. For rectal cancers, an MRI is done. So once this is done, what happens? It is an MDT. Cancer is not single modality treatment.
Okay.
The treatment of cancer is multimodality. So
Right.
the case goes to a multidisciplinary team. A multidisciplinary team involves the surgeon, the pathologist, the medical oncologist, the radiation oncologist.
Right.
So these all sit together and decide what's best for the treatment, or for what's best treatment for the patient. So for these colorectal cancers, upfront surgery is recommended.
Okay.
So you can go in, do the surgery, resect the tumor, anastomose the remaining colon, and then the final histopath will determine if the patient needs an adjuvant chemo, which is chemotherapy after. For rectal cancers, there's a more role for neoadjuvant chemo,
Right.
radiation, that you radiate the rectum, you give chemo, then decrease the size or decrease the tumor burden, then operate, and then give adjuvant.
So basically, it is a very big blessing that God has given to us in form of letting us know that cancer is there. So early detection is
Early
going to save
detection.
life.
Early
The
detection.
earlier we detect a cancer, the sooner we can get rid of it, and it isn't fatal anymore.
Yes.
We used to think cancer is fatal and
Yes.
feel terrified of it.
Exactly.
But now, as you're saying, even colorectal carcinoma or breast or any other cancer, it's resectable, right?
Exactly.
So what would be one take-home message to everybody out there, Dr. Junaid?
My take-home message to everyone is that whenever you have a medical condition, don't delay it.
Right.
Get yourself checked. Everything is important if you are healthy.
Exactly.
If you're not healthy, then nothing is important in this life.
Right.
Number one. Number two, if you have been diagnosed with cancer, you need to fight it. I know it's an
terrifying,
overwhelming
like, yeah.
news, but the good thing is, with new research and science, there are a lot of options for treating cancers. And people who have been diagnosed with cancers have been treated and have lived an absolutely normal life.
Thank you so much. Dr. Junaid Azad, who's a general surgeon as well as an oncology surgeon, and you heard it from him himself that he told you have to just keep your eyes, ears open and look for symptoms and signs that your own body is telling you. The once you diagnose them and get them detected in time, complete treatment is possible. Thank you so much for watching, and inshallah we'll meet you next week. Allah Hafiz.